All right, so I apologize. I just hit record, so I'm sorry. Increased leukocytes, okay. Confusion, okay. What else? Based on this here. So she's alteration in mental status. How about these signs up here? Urinary frequency, the urgency, the dysuria would be another reason why, something's not right or should be an indicator of why, she's not doing well. So, the temperature, an actual temperature is considered 101.4 or 101.2. So in that area, so she has a low grade fever, right? All right. So her indicators would be the frequency, the confusion, fever, suprapubic tenderness. Let's see, we did have that here, mild suprapubic tenderness, and her positive specimen. So what are her risk factors for a UTI? Besides age? Will be other risk factors. Okay, so she's more susceptible to dehydration. Also, because of her age, what would be the likelihood of her being able to, clean herself really well? She may not do as good of a job wiping from back to front. That's a great one. She had one before, correct, Moni? She did. So, she keeps getting them. So somebody needs to kind of investigate the process to see, hey, why does this continue to happen to her? The normal flora of the vagina can also, secondary to bacteria, some of that can cause her to end up with a UTI. And do elderly people drink a lot? Do they have a lot of, do they drink a lot of water or stay hydrated? No. So that's another reason why that can happen to her. So let's look at, we got age, we have gender, and those are the two causes. Okay. What is the priority nursing diagnosis for her? Because there's several that we can go with. Okay, pain related to dysuria. Okay. I like that. Any others? That's it? Only Kay Gannon? Anybody? So acute pain. What are some nursing and collaborative interventions to address the urinary pain that she's experiencing? So what can we do? Increase fluids. How much fluids can we tell her, if she was drinking PO, 2 to 3 liters, correct. 1,500 a day. I mean, it's even hard for non-elderly folks to get in 1,500. I said 1,500 liters, but I meant milliliters. That'd have been. She would be super swollen if she did that. Okay. Other things. How about, how to clean yourself, how to wipe. So kind of educate her on how not to, how to prevent UTIs. Take medications. Kind of monitor for the color change in urine to let her know if she's more dehydrated. No caffeine or alcohol. That's true. And don't think elderly people do not like to drink, because they do. So we're going to take her medications or an antispasmodic. She can do heat over the belly, warm packs, or sitz bath. Rest, increase her fluids, unless it's contraindicated. All right, so what else we have? What should a plan of care directed at tertiary prevention include for her? Tertiary plan. So primary is kind of getting the word out before we have drama. This is kind of the rehab stuff. Come on now, you guys can do it. Except for the person that's driving. So how about the follow-up, after completing the antibiotic, patient education, cranberry juice is good. So thanks, Marie. Cranberry juice would be a really good thing to do. Maybe some acidophilus, to help return good normal flora back to the body. Maintain fluid intake, so 2 to 2.5 quarts per day. Empty the bladder every 3 to 4 hours. Clean the perineal area from front to back or after voiding or defecation. Bubble baths. I mean, I don't know how folks can stand bubble baths because the products in that stuff is so itchy. Feminine hygiene products and vaginal douches. Wearing cotton underwear. Not wearing too tight clothing. Give some air down there. So, this is kind of a short case study, but for UTI, you can also have, bacteria, you can find a virus, it could be a fungus, and you can have a UTI in either the lower or upper portions of the kidneys, or the urinary system. If you have it in the lower urinary system, then it can migrate upward. So typically, this is where you normally have it. In the upper system, we're looking more at the ureters and the kidneys. So at the lower system, we're looking at the bladder. And if it's in the bladder, then they call it a cystitis. That would be a CYSTITS, I'm sorry. If it's in the urethra, then it would be a urethritis because that's where it occurs. So it's either in the bladder or in the urethra itself, which would be the tract that you would use to pee out of. If it's in the upper urinary portion, then that would be the ureters, and that would be a ureteritis. Or it could be, if it's in the kidneys, then it's a pyelonephritis. So if the bacteria gets all the way up to the kidneys, then that's a significant infection. And pyelonephritis is definitely a lot more serious than a cystitis would be. So here in the kidneys, if they have a pyelonephritis, then the circulation is nearby, and the infection can get inside the circulation and get into the body system systemically. It can go to the heart. The patient can get septic and they can end up dying. So more women are affected by urinary tract infections than men, and that's because the urethra is shorter than men, and making it easier for the bacteria to kind of migrate upward. Secondly, the close proximity of the rectum and the urethra makes it easy for bacteria to migrate over. So tight underwear, non-cotton underwear, cotton crotch is what they're talking about. So the seat of the underwear. Improper wiping, which is kind of what we already have discussed. So, the flow of urine is usually kind of downward. As we all know, it'd be kind of weird for it to go upward, but it's we do have systems in place to prevent the urine from backflowing. up into the kidneys, so that we have valves, we have the muscles of the bladder, we have pressure created by the urine that sucks the urine down to evacuate. So there's different, positive systems to prevent backflow. If you end up with kidneys backing up into the urinary system, then we've lost, or we now have, we open up the door for infections to start. So the ureteral vesicular valves is basically a one-way valve, and if it's dysfunctional, then urine can reflux back up into the kidneys. The urine itself is relatively sterile. It has antiseptic properties, so therefore it prevents germs from sticking to the bladder wall. It does help flush out. If you have diabetes, then the urine changes. So usually the glucose is about 100% absorbed in the PCT, which is basically the proximal convoluted tubule. But the diabetes person there's too much of it there. Remember I said if they have a glucose level greater than 180 milligrams per deciliter, then it's going to spill over into the urine. So when it's too much, it leaks into the urine, providing a medium for bacteria to grow. So basically it's like sugar urine. The bladder lining has an immune system, cells that kind of help fight the bacteria. So the lining will also attack bacteria. But if a patient's kind of immunocompromised, then that puts the patient at risk for bacteria growing. So if you're diabetic, they're more susceptible to infection. If they're immunocompromised, they're going to be more susceptible to infection. So for guys, looking at the prostate gland, when the prostate gland is enlarged, it doesn't secrete the fluid properly. So, and it's squeezing that urethral, it's squeezing the urethral shut, or making it close or tighten. So therefore the urine backflows, and you don't have the antimicrobial fluid to help ward off an infection. That's when somebody has an enlarged prostate. Normally, without that, the prostate gland, the fluid that it secretes is antimicrobial, and that kind of coats the urethra, therefore preventing bacteria from, wreaking any kind of havoc. But if they have a swollen prostate, then that antimicrobial property is lost. So if they do something like Lactobacillus acidophilus, then that will help to prevent, or it'll create an environment that's not conducive to bacterial growth. So it keeps the environment more acidic, and that's because it's working together with the vagina. All right, so one of the main bacteria that you'll find is E. coli, and it's primarily from the digestive system. So other causes could be hormonal changes like pregnancy or menopause or birth control pills. That changes the normal flora. Antibiotics, actually, it will kill all bacteria. So, if you have a bronchitis, or like an acute bronchitis, and you're taking medications for it, it's going to kill all bacteria. So the good goes along with the bad. That opens up the door for bacteria to grow. Renal stones or kidney stones cause a blockage, and it prevents the urine from draining, or allowing the stone to pass. So the stone could be in the calyx, it could be in the pelvis, or the pelvis area, the upper ureter, or the urine can be stagnant. So if you have a stone, then the stone blocks the urine from being able to drain. Diabetes, we've already talked about that, because of the compromised circulation and the decreased immune system. They end up with glycosuria and urinary retention, because the nerves are not working properly and the bladder gets distended. Toiletries, so excessive bubble baths, powders, and perfumes, scented tampons, sanitary napkins, and even unscented tampons can also put you at risk for a urinary tract infection. Guys with an enlarged prostate, so prosthetic or obstructive prostatic hypertrophy or hypertrophy. This would be the urinary retention decreases the microbial or antimicrobial fluid. It compresses the urethra, so that we talked about that already. One I didn't talk about is a congenital defect, which is the vesicular or vesico-ureteral. It's the vesico-ureteral reflux. So VESICOURETERAL. Okay. Can we mute either our phone or our computer? Because I'm hearing, signal lights and kiddos, and so can we just go ahead and do that real quick? Thank you. All right, so VUR, which is vesical ureteral reflux, so VESICOURETERAL reflux. So this is a congenital defect that's kind of seen in our pediatric population, where the urine it backflows from the bladder to the kidneys because of the valve defect doesn't close properly. So then that would be another reason why that kiddo would be susceptible to frequent urinary tract infections. An overextended bladder, so the bladder doesn't empty regularly. So, when you're trying to hold it and all that, that sets up a urinary tract infection. So, creates a weak bladder. So nurses are at risk because if you're busy, you really don't run to the bathroom, you don't have time. But you actually predispose yourself from developing UTIs. Indwelling catheter or invasive procedures, intercourse if the spermicides are used. So void after having sexual intercourse, it's very important to help flush the system and make sure that the urethra does not track any bacteria. Indwelling catheters are basically breeding grounds for bacteria to grow. And then if someone is already immunocompromised, they can't fight the infection. So they tend to develop more viral or fungal UTIs versus bacterial. So how do we, what kind of diagnostic tools or diagnostic studies do we want to do for a patient that has a UTI? If we're looking for that. So we want to do a UA. And what are we specifically looking for in the UA? Culture and sensitivity, that's another one. What are we looking for in the urinary the urine analysis? What did Our Lady have? She had leukocytes, right? And then they would send it off for culture for bacteria. So our role is to try to get a clean catch as nurses. We want to best collect it when the bladder has been full for about 2 to 3 hours so that the urine is concentrated. So we're going to make sure they wipe with an antiseptic wipe, void a small amount, and then void into the cup. Urine culture, we're going to use that to determine the type of bacteria that's growing in the urine. So this takes about 2 days to get the results back, but they'll go ahead and start them on a broad spectrum antibiotic and get the culture before we start them on the antibiotic. That's important. The other thing we could do is a cystoscopy. So cystoscopy, cystoscopy. So this looks at the inside of the bladder and the urethra. And usually if you have recurrent UTIs like this patient that we did a case study on, then they will tend to do a cystoscopy to see what's going on. So the patient will complain of burning sensation, pain to void, and they'll have urinary frequency and urgency. It feels like they have to go really bad. And when they get there, the bladder and the urethra will start to spasm, which creates the pain. And then when they finally go, it's just like a small little trickle, and they'll have hematuria, which is blood in the urine. But only small amounts are going to come out, or nothing. So the bladder's highly irritated, the urethra is inflamed, so that's where they get the urinary frequency. It could be the urine can have an odor to it. It's usually dark and cloudy. The patient will also have pain at the costovertebral angle. And the costovertebral angle is right at the angle where the lower ribs in the back and the kidney come together. So there'll be tenderness in that area. And if you basically just put your hand over it and then kind of hit your hand lightly. If the patient feels that, then this is associated with a kidney infection. Spasms of the bladder, fever, increased white cell count on UA. We already found out that the geriatric population, they do not have the textbook presentation. They usually have sudden confusion or agitation or an alteration in mental status, which will then increase their increase the susceptibility of them having falls. No fever or very little, but needing to void constantly. So they'll constantly say that they have to urinate. So some of our interventions would be to assess for the signs and symptoms of a UTI, keep them hydrated. So they should be putting out urine at least 30 mils per hour. If not, it can lead to renal failure. And, you know, as we said, some of that, if the bacteria starts to backflow up, then that's going to make the condition worse if they end up with pyelonephritis. We need to educate the patient how to prevent a UTI, making sure they take all the antibiotics, monitor themselves for UTIs on a consistent basis and complications. Our other intervention is making sure we get a UA, get a CBC, do a gram stain and culture, remove Foley's if it's there and the patient's UTI is due to a Foley, or even urosepsis. So those poor nursing home patients that come through and they, you know, have a Foley place, and you look at the Foley, and right where the Foley and the orifices or the hole, for lack of a better word, it's all brown and the urine's kind of tea colored. That's not good. So encourage 2.5 to 3 liters per day to help flush out the system, keeping the urine kind of diluted to decrease infection. As she received Bactrim is which is a sulfonamide, it's one of the mainstay antibiotics that's given. They need to take it at the same time every day to keep the blood levels constant in order for it to work. They should be voiding every 2 to 3 hours. And let's see what else. As far as pain, I mean, they can do, you know, the warm belly pad, or whatever you want to call it, heating pad. That's the one. They can take pyridium. Now, what's specific about pyridium? What is it going to do to the urine? Correct, Kay Gannon. It's going to turn the urine orange, or an orangey red color. So that is normal. So they can do like a sitz bath, a heating pad. They could do analgesics to coat the bladder to help prevent spasms and burn in the urine. And it will stain their clothes. So hopefully they get some, you know, the BUP underwear, the backup pair. So let's focus on education. So we're gonna, you know, take all the antibiotics. We want to make sure we teach them the white from back to front or front to back. Which one? Front to back. Should they be having, what kind of education you want to tell them in regards to intercourse? To make sure that they pee afterwards, exactly. Underwear. What should we tell them about underwear? Go Commando? Cotton, loose fitting, yes. And if you like the little nylon panties or whatever, silk underwear, the crotch just needs to be, have some cotton in it. What about bubble baths and, spraying perfumes and body sprays in that area? Should we continue that? No, we want to avoid that. What about powders? Nope, we don't want to do powders either. And they have actually identified some powders to ovarian cancers. So, people that use that Johnson and Johnson or baby powder or any kind of scented powders. I was trying to think of there's another one out there that folks use on a regular basis. But even those, they're saying not to use. So how often? So when you're on your period, this is for ladies, but guys, you're gonna have to talk about that too. What about use of tampons and pads? What should they do there? Yep, change every 2 hours, not overnight. Exactly. Unscented would be great to do that. So change pads often, avoid tampons. What about caffeine and liquor? What about that one? Should we drink a bunch of liquor? Okay, fat finger Franny. Go ahead. Oh, that was me talking. Okay. So, yes, we're going to avoid caffeine. We're going to avoid liquor because they both irritate the bladder and the urethra. So, we need to get them peeing every 2 to 3 hours. What, trying to see how to word this question. What else can we have them take over the counter that prevents bacteria from sticking to the bladder wall? Okay, so cranberry juice helps to flush the kidneys and it's kind of good, but what else? The azo is more like the pyridium. It's not that one. Vitamin C, that's correct. So take vitamin C, 1,000 milligrams, and that helps to prevent the bacteria from sticking to the bladder wall. So that is correct on that. So are there any questions? Any questions related to UTI? Did I kind of cover it? Okay. No questions. All right, so let me stop sharing. And then we'll move on to the next case study. All right, so let me get the vignette up. How does beer help with passing kidney stones? What's the link there? If we're saying, we're talking about just UTI. So if it's going to irritate the bladder, then how would beer help with passing kidney stones? Anybody? I'm not sure about the beer and the kidney stones. I'd have to check on that one. But if we're talking about we're talking about urinary tract infections and how it irritates the bladder. I'm not really sure if drinking beer with a kidney stone would be the right thing to do. Now, most people probably drink the beer because, they're inebriated and they may not feel the pain as much. So maybe that's the reason why someone says drink beer. That's the only thing I can think of why somebody would drink beer with a kidney stone. That's my thought on that. All right, share screen. And I am going to this one. Okay, so here's a case study. Ooh, be good if you could see it. So Lucas is a 17-year-old high school senior who experienced an ankle inversion injury during basketball practice. His initial signs and symptoms included swelling over the left ankle or left lateral malleolus, which is the ankle, pain at the site of injury, and limited weight-bearing capability. His coach wrapped the ankle with an elastic bandage, placed an ice pack over the left lateral malleolus, and elevated his left leg. When Lucas's mom arrived to pick him up at basketball practice, she took him to the local ED. So at the emergency department, assessment findings are significant swelling, redness, and warmth over the left lateral malleolus. He has full range of motion of the ankle joint, and the joint is stable. He complains of throbbing pain at the site of injury and rates his pain at a 4 on a 0 to 10 scale. His toes are pink and warm with brisk capillary refill. His left pedal pulses are present and strong, and sensation in his left foot is normal. He gets an x-ray, there's no fractures. The ED physician diagnoses is first degree or mild sprain of the left ankle. So they prescribe rice for Lucas's left ankle and acetaminophen or ibuprofen for pain control. So what is a first degree sprain? No damage to the tendons or muscle. Is that correct, everybody? All right, Kay Gannon. Basically, this includes tears to the ligaments, but the joint is not impaired. So the tendon's not involved. So that's true. So a first degree tear is one that includes the ligament. So it tears a few of the ligament fibers of the joint, but the joint function is not impaired. All right, so correlate the signs and symptoms that Lucas is experiencing with the inflammatory response of tissue to his injury. So let me just roll it back up. He had swelling, redness, and warmth. He did have full range of motion. He had pain. His toes were warm and pink with brisk capillary refill. So redness and swelling and warmth are all caused by the tearing and the trauma to the foot, however which way it came about. So basically the inflammatory process, that's usually your signs and symptoms. And could he bear weight on it? Let's see. He had limited weight bearing. So, that's all related to the trauma he sustained. So the blood flow increases to the site. So that's the warmth and redness. Blood vessels leak fluid into the tissues. At the site of injury, that's the edema, white cells migrate to the area. Increased nerve sensitivity, pain, and decreased joint mobility results from the ligament damage and edema of the tissue at the site. So that's how you link his signs and symptoms to the inflammatory response. But anytime you have an inflammatory response of any kind, we're going to get warmth and redness and swelling and leaky capillaries and white cells migrating to the area, pain, decreased mobility, or use or function if it's an extremity. Pardon me. What is rights and what is the rationale for each of these interventions? All right, so rights is rest, ice, and what else? Compression. Last one. Elevation. Thanks, Ashley. So why do we want to rest the joint, or why do we want to rest the ankle? What's the purpose? If we're up jumping around on it, what's going to end up happening? So we're going to rest it to allow healing. If we jump around, then it's going to be further irritated. We can actually complicate the injury or further damage something that was probably small. Now we're going to make it big. So we don't want to cause additional damage. So thanks, Moni. And trying to get the name here. It just says BRE. And as well, Amy Lee. All right, Brea. Thanks, Brea. All right, so rice, ice, compression, and elevation. So we're going to prescribe rest to allow the ligaments to heal and prevent further injury. Ice, and you should do this for any injury for the first 24 to 48 hours to help reduce the swelling. We're going to put compression on it. Because your swelling should be down, and that's to help minimize injury and helps promote the healing process. Someone asked, why is rice method used for sprains? And it's not the rice method that's used for sprains for only 24 to 48 hours. It's just the ice part. After that, by 48 hours, your swelling should be down. So if you're elevating it above the level of the heart, you're putting ice on it like every hour. You put ice on it for about 20 minutes. Then the swelling should be moving into a different stage. So at that point, you could use heat if you wanted to, but the ice is good for the initial process to help decrease inflammation. Does that make sense? Okay. So compression to decrease the edema at the site of the injury and decrease pain of movement, and elevation is basically to decrease the edema at the site. So all four of those are working together to get the same thing done. Decrease swelling, promote healing, allow for the person to get better quicker. And that's the reason why they're doing the rice. How is the collaborative care for an ankle sprain similar and different than the collaborative care for an ankle fracture? Good question. I like it. All right, so yeah, we still need to reduce swelling, so that's the same. Yep, how is it different? So only one person has reduced the swelling? Anything else? So, okay, someone wrote immobilization for a fracture. That is true. The patient with an ankle fracture will have a boot on to keep the ankle from moving. So with a sprain, you're using the compression or the elastic band to kind of hold things together, because remember, the joint is still stable, it's not unstable. With a fracture, the joint would actually be unstable, which is the reason why we want to do immobilization. We would still do ice, we're still going to rest it, and we're still going to elevate it. So they share some similarities in the management, but at the same time, you know, there's a difference. We don't need to split per se the a sprain, but it's gonna hurt like heck. Trust. I had a sprain about a year and a half ago, and just tripped over air. I really didn't have a story to say, you know, a good story. Just somehow misstepped and boom, that was that. But my ankle was bruised, it was swollen, I could barely walk on it. And I had some kind of ankle boot. It wasn't like that 3D boot. It didn't go up my leg. It was just those sorry boots with your foot go through it. I just said, this is a bunch of buffoonery. But I had to keep the ACE wrap on. It definitely helped help my foot, or help me, you know, walk on it better. I didn't need crutches, thank God. But I have broken my foot too, so moving on. So the only thing we didn't talk about was pain management, but we'll need that as well. So depending on the degree of the sprain and the stability, a splint or other brace may be required. Ankle fracture is going to be immobilized with either a cast or a bracing material. So neurovascular assessment is going to be extremely important, especially for the person with an ankle fracture, because we want to make sure that, you know, we haven't lacerated blood vessels or nerve endings or anything like that. So that would definitely be the difference in how we're going to manage their care. Any questions on sprains? So go back and look at the different types of sprains in your book. You know, make sure you know signs and symptoms, you know, diagnostic studies that would need to be done. Most of it's going to be your assessment, the bruising, the redness, the swelling, the tenderness upon, or, you know, pain upon palpation. So those are going to be some of your mainstay. But knowing that you would have to, the treatment is going to be rice, and making sure you ice it for the first 24 to 48 hours, and that you rest it to promote healing, elevate it, and make sure an ACE wrap is on it. All right, questions about that? Are we good on ankle sprains? Yay! All right, so let's look at pneumonia. Oh, somebody has a question. Hold on. Oh, cool. So let's look at pneumonia. We have aspiration pneumonia, and what's the difference between that and regular pneumonia? We're talking aspiration versus pneumonia, period. So aspiration pneumonia is caused by dysphagia. Okay. I don't disagree, but usually somehow, some way, okay, pneumonia is caused by a bacteria. So what can happen, or aspirated material? I kind of like that one better, with the aspirated material. Thanks, Marie. So with an aspiration, the person usually vomits some type of material, and we're talking about acidic material coming from the belly. So it's like a chemical, it's actually just gut intestines or stomach secretions that end up into the lung, which definitely, it's acidic, and the lungs is not going to like it. And that's what it basically boils down to. So we have gastric acids that's causes a chemical pneumonia. You also have aspiration of bacteria that can also happen from an oral or pharyngeal area, so that can happen. And more specifically, it's like if someone has a sore throat, or and they have an abscess in the back, like a peritonsillar abscess, and somehow it leaks and that bacteria is allowed, you can accidentally, have that inhaled down your trachea. aspiration of a foreign body may cause an acute respiratory emergency depending on what it is. So, you know, certain things children shouldn't eat. You know, you all call them pecans, we call them pecans, whatever. Or you all call them pecans, we call them pecans. However, you know, I had a little kiddo that he was actually eating one of those, and he should have been okay. He was 2 years old, wasn't that big of a deal, but he inhaled it and it went down the trachea and not the esophagus. And so they were doing, you know, they were doing chest compressions. It really wasn't CPR, but they were doing chest compressions to kind of get the foreign body out. And so when they arrived at the emergency room, you know, they're back there saying, now, how old is he? What is his, you know, history? And I'm like, okay, what happened? I thought, you know, you said you had a code, blah, blah, blah. He was like, oh, all of a sudden the patient just, you know, pink tissues, you know, return to spontaneous circulation. And I'm still like, freeze. What did he swallow and where did it go? So did it go down the esophagus? Did it go down the trachea? Nobody seemed to be that concerned. They were just so excited that the kiddo was no longer struggling. So about 2 hours later, the kid had a history of bronchiolitis, and it was a preemie baby. So that was why I was on high alert, because the patient already had respiratory compromise. So about an hour or so, hour and a half into it, his SAT started to decrease. He started to develop abnormal breath sounds. And so I asked for the emergency room physician to do another evaluation on the kiddo. He said the kiddo was fine. They did a chest x-ray. We're good. And so they sent the kiddo home. About an hour or two after being home, he went into severe respiratory distress, had to be transported to Cook's or to Children's in Dallas, and they had to go in and do an emergency bronchoscopy. So that's exactly where the pecan ended up, in the bronchial tract. So I was right the first time. But moving on. So always trust your instincts. I mean, you can only lead the horse to the water. You just can't make him drink. All right, moving on. So how do you know if someone has aspiration pneumonia? What's your, you know, what's your signs and symptoms? Productive cough. Maybe. If someone has an aspiration pneumonia, more than likely they have an impairment of their airway. So like their gag reflex, so they could have coughing, ciliary movement. It's going to be by assessment. So if you're suspecting that it was aspiration, it'll be based on, oh, well, we had some vomit material, you know, in the mouth, and you should just highly suspect it. More than likely, the patient probably inhaled that, and some of it went into the trachea. So it can occur in the community setting. It can occur at the, you know, healthcare facility. Either situation, doesn't matter whether it's in the community or if it's in the hospital setting. Then that person can end up with anaerobic organisms alone or in combination with other organisms. And now this aspiration pneumonia just starts to go haywire. Other things that can complicate an aspiration pneumonia is someone with poor dentition, poor oral care, periodontal disease. There's other factors like alcoholism that suppress cough, mucociliary clearance, phagocytic efficiency. So all of these play a role. So usually this particular individual, they will can either have mild illness or they could actually be critically ill. It just depends. They could be in septic shock or respiratory failure. It depends on how bad the situation may be. So if you have somebody like with a stroke, then that may have had a stroke previously, then they can, you know, we want to think about swallow studies to make sure the patient can swallow. If they have any history of esophageal diseases, being in a nursing home, chronically fed by a feeding tube, all of those are predispositions or presentations. Okay. Let's see what else. So tachycardia, tachypnea, they could either be febrile or afebrile. Decreased breath sounds, that's going to be one of your hallmark signs. Dullness, so dullness if you do percussions, rails, egophony, which they'll say 99, 99, 99, or blue moon, blue moon, blue moon. If you put your hand on the back of a patient and you have them say 99, you should feel some vibration back there. But if not, then there's some consolidation in that area, which means the patient probably has pneumonia. So that's known as tactile fremitus, by the way. Alteration in mental status. So for elderly people, if they have pneumonia, then they're going to present with decreased mentation or confusion, or an alteration in mental status. So you're just kind of looking at it as a suggestive sign as to why they may have an aspiration pneumonia. Laboratory studies are pretty much going to be guided by the patient's presentation, but chest x-ray would definitely be a good thing to do, and they will probably have like infiltrates on their chest x-ray. Questions? Concerns? And this is just for aspiration pneumonia, so we're not anything else. Will they need antibiotics? Yes or no? They might. They may be on a ventilator. They need antibiotic support. They may need speech therapy depending on the situation. All right, so antibiotics that they may end up receiving would be like vancomycin or clindamycin. Those are some common ones that's normally done. Some of the cephalosporins may be used. Levaquin or levofloxacin, that may also be used, but they can also use that same one, Levaquin, for regular pneumonia. So we're going to talk about that one here in a little bit. Prognosis is usually okay if it gets caught in enough time. So if the person's going to die, then they'll probably die within that first 30 days. So, and especially for an elderly person, remember they don't have a lot of ciliary function. Their respiratory drive and reserve is diminished. So we have to be careful with that. We just can't say, oh, it's just pneumonia. For elderly, it's a huge deal. Same thing for kiddos. It's a huge, huge, huge deal. The other thing they may consider is maybe doing some steroids to help decrease inflammation. And then, working with the patient with coughing and incentive spirometry, etc. Does that all make sense? All right. So I don't know if I have let me see if I have check real quick and see if I have a pneumonia case study that we can do real quick. Did we cover appendicitis in class? I think we did. Okay, cool. Let's see, I think I have. Okay. We'll do that. All right, so I'm going to share my screen. All right, so here we have can you guys see that? I hope so. So here we have a 71-year-old that's brought into the primary care, and he came in to the clinic. Let me make that bigger. He came into the clinic with a fever 2 days ago. He has shaking, chills, productive cough, and he can't lie down to sleep because he can't stop coughing. So he's examined. They decide he has community-acquired pneumonia and admitted to the floor. The intern is busy and asks you to complete your routine admission assessment, and you call her with your findings. Okay, so let's just kind of back it up a little bit before we get to the first question. So pneumonia is basically a widespread disease of the lungs, and usually the lower respiratory tract infection, it's usually a lower respiratory tract infection that yields inflammation of the alveoli. So we know that the alveoli is responsible for our gas exchange, but we kind of lose out on the oxygen, but we end up with more of our CO2, and so the patient develops something called hypoxemia, which is decreased oxygen in the blood. So when we have this infectious process in place, then the alveoli become inflamed and they will fill with fluid, as well as red blood cells and white blood cells. Okay? If you have pneumonia, you can have a viral pneumonia, and primarily kiddos get viral pneumonias. They get viral and bacterial. Adults usually, they can have a viral pneumonia. They can also have a bacterial pneumonia, and if they're immunocompromised, they can end up with a fungal pneumonia. So the lung parenchyma, whether it's the alveoli, the alveolar ducts, or the bronchioles, that's the gas exchange trio. So we need those to be functioning properly to help prevent or fight off germs by filtering the air through as we go, filtering out the bacteria. There's certain conditions that's going to decrease the ability of the body to, to get rid of the germs. So things like a prior infection, like a flu or a cold, and that's usually how kiddos develop a pneumonia. They'll start off with what they call an upper respiratory infection. So a little runny nose, a little cough here or there, MBD, no big deal, and it's usually viral. And then somewhere along the line, it doesn't get treated appropriately, and then the kiddo ends up developing a bacterial pneumonia. So a flu or cold can actually do it. Weakened system, so what the very young and old in HIV and those patients on autoimmune medications. So if you're immunocompromised or you're on autoimmune medications, then that will also lead an individual to develop pneumonia. Patients that are immobile, so if the patient had a stroke, they have decreased neural status, then they're going to be at risk for aspiration pneumonia. COPDers, so that's another one of our exemplars, right? So remember I said if they have a fever, then they may have an underlying infectious process like a pneumonia. Smoker, same thing. Post-op, especially abdominal and thoracic surgery. So that's the reason why we do the incentive spirometry to help with the pulmonary toileting, to turn, cough, deep breathe, etc. Get those lungs working. So any questions are kind of about the background related to pneumonia? Okay. If they have a viral pneumonia, the causative agent for that is RSV. Where did we learn about RSV before? What exemplar did we talk about RSV?
Colitis.
It was part of gas exchange, but which one? That's the concept. What exemplar?
Bronchiolitis.
So bronchiolitis. That because when they have bronchiolitis, that was the causative agent. And do we do any type of contact isolation for them?
Yes.
Yes. Okay, so Thank you guys. So influenza would be your other causative agent if it's a virus. Okay, so this is how you kind of tie those pieces together. Usually physicians will not diagnose a kiddo with asthma, and it varies between, groups. It could be after a year or after 3 years. So it just varies. But up until that point, it'll be categorized as bronchiolitis. Bacteria wise, which is the most common, especially in community acquired pneumonia, the most common form is going to be Streptococcus pneumoniae. It's an atypical bacterium, can also be can give a person pneumonia, and that'll be mycoplasma pneumonia. So this is called the walking pneumonia when it's atypical. So usually the signs and symptoms are milder but not as severe. If you get a fungal pneumonia, then that individual has a weakened immune system, and they can get it from plants and or animals. So that doesn't even sound good, especially if that person's, have a green thumb. So community acquired basically means that they got the bacterium or the germ or the organism outside of the hospital setting. Hospital acquired or nosocomial basically means while the patient was in a medical facility, whether it was hospital, nursing home, or whatever, they developed the pneumonia. So usually the patient may have been on a ventilator, and if you have a ventilator patient, they're at major risk for developing pneumonia. The patient may have been hospital acquired is hard to treat, bacterial resistant, and usually develops within 3 to 4 days or 2 to 3 days after admission. So 48 to 72 hours post admission. So the best thing we can do for these folks is to make sure we do a good neuro and respiratory system exam, especially if they're elderly coming in confused. Two things we should be thinking: pneumonia or a urosepsis or UTI. So auscultation, we may hear coarse crackles, rhonchi, lung consolidation, fever they may be coughing up sputum. And then you want to look at what color the sputum is. Usually if it's yellow, that's more of a bronchitis, but when you're looking at pneumonia, it's more, it could be brown, it could be rust colored, and depending on the bacterium, it's going to determine what color the sputum is. We want to get a chest x-ray, and we do want to have them cough up some phlegm and send it off to the lab for culture and sensitivity. Okay, so productive cough, pleuritic pain, neurologic changes, especially in the elderly. They'll get fatigued very quickly, have an increase in respiration but no fever. We would be looking for an increase in the WBCs, right, on CBC. Abnormal breath sounds. If they have their fever can vary. It could either be mild or high. So bacteria will increase the temperature, sometimes greater than 104 degrees. SATs, there may be less than 90%. That will be highly significant. So they're going to need supplemental oxygen. Nausea, vomiting, achy all over, activity intolerance. So anytime they have to get up and do anything, if you're just, having them go to the restroom, they're going to be extremely tired. Okay. So monitor respiratory status, as I said, auscultate breath sounds, see if they're getting better. Monitor oxygen sats, monitor heart rate and respiratory rate. Skin color, we want to know if they're cyanotic. We want to know if their lips are cyanotic. If that's the case, then that's not good. What is that called when your mouth has cyanosis? Anybody? No one? Isn't that the circummoral cyanosis with just the bluish discoloration around the mouth? So that would be significant. Okay. Circummoral, Circumoral. Circummoral cyanosis. So you don't want to play around with that. Usually seen in kiddos, but it's basically a blue discoloration around the mouth only. Okay. We want to check arterial blood gas results, and you may not have looked at the acid base, but we'll see. We'll see if you did or not. Get a sputum, as I said, have suction available, and then we need to make sure we give them breathing treatments. So they're going to need bronchodilators to help, help them breathe better. So based on all of those components, and then we'll talk about education in a little bit, what would be 4 priority areas to include in your assessment? So to bring it back full circle. O2 sats, auscultate lung sounds, okay? Check symmetry of lungs, check for cyanosis due to decreased oxygen. Okay, I like that, Kay Gannon. Anything else? We want to check mental status. We want to check respiratory status, oxygenation status, anything else we want to check? Cardiovascular, maybe? Let's see what they come up with. Vital signs, cardiovascular and pulmonary components, and determination of mental status. Ask about current medications, previous medical history, presenting symptoms. If they've had a history of pneumonia previously, here's a very good one. Did they have the pneumococcal vaccine? So if they're immunocompromised, they should get that, right? And did they get their flu shot? So all of those are good things to ask. All right, so we're going to move through. This is what we get on our assessment. So, blood pressure's up, they're tachycardic, respiratory rate's 32, they have a fever, and their sats are 84%. Now, this is a 71-year-old person. So you auscultate breath sounds, and they're decreased, and they have coarse crackles in the left lower lobe anteriorly. Should we listen posteriorly? Yes, we should. So they listen posteriorly. His nail beds are dusky. Does that sound good? No, things are, where's everything going? Where's the blood flow going? To the heart, brain, lungs, and kidneys. That's where it's going, to the major organs, heart, brain, lungs, and kidneys. So he has a productive cough. Oh, I just talked about this rust-colored sputum. That doesn't sound good. He complains of pain in the left side of his chest. That's that pleuritic chest pain when he coughs. He is a lifetime non-smoker. So past medical history, he has coronary artery disease. He had a MI with a stent. He's on low pressor. He's on amlodipine, lisinopril, Lasix. For his type 2 diabetes, he's taken metformin and glipizide. He has never gotten the pneumovax or flu shot. He reports getting hives when he took an antibiotic pill a few years ago, but doesn't remember the name. All right, so which of these assessment findings are significant? Dusky nail beds, I agree. Coarse crackles. Heart rate. Oxygen sats. Those would all be concerning. Rust-colored sputum. Diabetes, is it going to heal up pretty quick? Or will he have delayed wound healing? So we got to be extra vigilant. All right, so pulse, respirations, temperature elevated, SpO2 indicates hypoxemia. I didn't see hemoglobin and hematocrit, but we didn't get to the labs yet. Breath sounds are decreased, the crackles, the left lower lobe may indicate fluid accumulation or atelectasis. What's atelectasis?
No.
Atelectasis is alveolar collapse. That's what it is. So that's the reason why that pulmonary toilet would be good, because if we start now having alveolar collapse, then that's going to be a huge problem or a bigger problem. Dusky nail beds, so good, K. Gannon, on that. Indicate a lack of oxygen uptake in the tissues. Rust-colored sputum and probable infection. Pain with coughing is consistent with inflammation or infection. Allergy to the antibiotics, so we need to figure out which one so that we don't cause an anaphylactic reaction, because he's going to need antibiotics. The presence of comorbidity. So I only addressed the diabetes, but he had a heart attack, so this is stressful. He has coronary artery disease, so we're going to be concerned about decreased blood flow. So all of these things increase his ability to die. All right. So here's our chart. We got him on some fluids. We check him vitals every 2 hours. He's on a 2,100 calorie diet, diabetic diet. We put him on a cephalosporin, and we're giving him some breathing treatments. We're going to titrate the oxygen to keep it over 90%. We're going to get a sputum for culture. We're going to do stat blood cultures and sensitivity, a CBC, a basic metabolic panel, which is basically a sodium, potassium, CO2, chloride, BUN, and creatinine, chest x-ray, and then we're going to continue home medications. So you get the doctor's orders, outline a plan of what you need to do in the next 2 to 3 hours. What are we going to do? So if this is our patient, we just got him, what are we going to do? Okay, start some oxygen. Okay, I like that. We're going to basically follow through on these orders, right? Start an IV, get everything placed like it's supposed to, get a breathing treatment, and we're going to monitor the patient for their responses. We're going to be checking vitals. We're going to see if the patient gets worse or better. You know, we want to make sure we know what those x-rays are. We're going to be checking to see if he starts to go downhill, because remember, he is 71. So start the oxygen, get the blood cultures, start the breathing treatments, get the x-ray, you know, try to get the sputum culture, get an IV line. We're going to get the IV fluids going, get the blood work, and then repeat vitals and assessment as needed, and then reconcile the home meds. So why do we give them D5 half an S? What's our rationale for giving him D5 half an S? He is a diabetic. I agree.
To hydrate him.
To get him hydrated. Why not just regular normal saline? Okay, hypoglycemia. Because D5 half an S is a hydrating fluid. So it provides more water than is required for excretion of salt. And he has an infection, and he's going to need extra hydration to help the body get rid of the toxins. So putting it at a rate of 125 is considered adequate maintenance of normal fluid balance. But because he does have diabetes, it's going to require frequent monitoring of his glucose levels. And since he is hospitalized, his blood sugar levels are going to go up as well, correct? Because for adults, when we're stressed, our blood sugar level goes up. But for kiddos, when they're stressed, their blood sugar level goes down. So what is the rationale for ordering oxygen to maintain SATs greater than 90%? Doesn't he have, like, gunk in the lungs and the alveoli? So, fluid and red blood cells and white blood cells. So we want to make sure that we're giving them some extra O's to help improve oxygenation and get rid of dusky nail beds, right? So the saturation of 90% means that the partial pressure in the arterial blood is approximately 60, and we want to keep it at 80 to 100. Below this point on the curve, the slope becomes very steep, which means small decreases in hemoglobin saturation reflect larger decreases in oxygen sats. So it's just kind of a mathematical equation is what they're doing here. So what is a CNS test, and what role will blood and sputum cultures play in his care? Isn't that culture and sensitivity? Why do we care? What's important about that? So as why would a nurse be concerned about culture and sensitivity? Because it's going to assist in getting the proper antibiotic, correct, to identify the organism to treat. But why the blood cultures? What is significant about the blood cultures? To see if the patient is septic. That's correct, Kay Gannon. So the terms mean culture and sensitivity. So, it's a growth of an organism in a nutrient medium, which we've talked about. After that microbe has been isolated, its susceptibility to specific antibiotics or sensitivity of the microbe to drugs is determined. If required, a broad spectrum antibiotic is given until they get the results back, and a more suitable antibiotic can be prescribed. All right, so what would you expect the chest x-ray to reveal, since we know he's coughing up sputum? Pleural effusion, he could. They have accumulation of fluid. He could have an effusion there. But we would infiltrates would be the thing, not the past infection. He has an infection currently. So in a patient with pneumonia, you would expect it to have patchy areas of consolidation, and that's where the bacteria is growing. Other findings would be the size and fluid accumulation in the lungs or the pleural space or around the heart. So congestion in the large vessels of the chest, and presence in position of any chest tubes or catheters. All right, let's roll on. So you need to follow a specific protocol when obtaining peripheral blood cultures. So put these in order of how it should go. What's the first thing you should do? Which number? Number 4. That's the first thing. Okay. Second thing. Number 1. I agree. Next, so once we select our site, then we're going to do what? Perform the venipuncture and collect 20 mils of venous blood. Okay. Third. Now this is between 2 and 6. So you either go aerobic then anaerobic, or anaerobic and then aerobic. You're like, dang. So we'll hang tight on that one, because you're all like, oh, I don't know. Okay, someone jumped out on a limb. They said 2 before 6, so we'll see. All right, last thing we're going to do is what? Number what? Number 5. All right, so let's see if we do aerobic before anaerobic. We do anaerobic before aerobic. We do anaerobic before aerobic because aerobic has oxygen and we don't want to add it into the anaerobic bottle. So that's why we do that one. That was actually kind of cool. All right, so the pharmacy sends up ceftriaxone because that is what was ordered. And we need to infuse this. All right, here's a little math problem for you guys. Let's see who's going to get the answer to this one first. So here's your medication. You need to give it over 40 minutes. So what is your milliliters per hour? Let's see who come up with this answer first. And remember, any IV fluids do not have a decimal point. They're always a whole number. Don't call out. Just kind of send it through the little chat, so that way everybody gets a chance to work that problem. Anybody? I only have one taker on it. Come on, you guys got to do. Some of you still got to learn how to do this math, or you having math struggles. This would be a good one, and this is actually not that difficult of a one to do. So all the information you need is there. Somebody goes, "I'm a nurse. I should know. I love it." Okay, Amy. I see you put something out there. All right, so there's two of your classmates that put the exact same number out there. Are you all in agreement? We have a third one that's put it out there. All right, let's see. Shinri, okay. I see you. All right, so for those that have been, silently wondering if they're correct or not, they are correct. So you would divide 40 minutes into 100, and you should get 2.5. And then since that was minutes, we're looking at hours. You multiply 2.5 times 60, you'll get 150. So if you needed to give it over 30 minutes, then if you were given 100 mils over an hour, it's just going to be 100 mils. But if you need to give it in half the time, then your rate needs to be doubled. Does that make sense, folks? Okay. So if you need to give it in double the time, meaning if you need to give it in 2 hours, then you have to slow the rate down, which means you're going to half the rate. So 100 mils is, some of these even number volumes and smaller volumes are you can almost look at it and say, so even though this was 40 minutes, I knew that it was going to be more than 100 milliliters per hour, but less than 200 milliliters per hour. I knew that. because I was greater than an hour. I was under an hour, but more than 30, if that makes sense. All right, so let's roll on. 150 mils per hour. So they same thing of what I told you there. So 100 mils divided by 40, and then times 60 equals 150. So how will you ensure that the home medication list is accurate? Can we have them, like, bring their medication bottles in? Can we verify it? Would that be a good idea? Have family bring it in? Okay. So there are 4 steps to make sure home meds are accurate. First, obtain and verify the patient's medication history. So all medication he's on, that he's taken, the name, dosage, route. Once it's compiled, validate that that is the current list. It's complete. Document the medication list on his record. Place his home medication list in a highly visible area so that other members of the healthcare team have ready access. And if you don't think that patients won't take their own medications in the hospital, sometimes they can, because the hospital does not have it on formulary. Okay. Last thing, ensure that the orders are written for the hospital medication regimen. This would be done by the healthcare team. And finally, create a medication administration record according to your facility policy. So let's roll on. So now the next day, this is what we have. Vitals still look kind of the same. At least the heart rate went down to 92. We're not breathing as fast. He's still febrile. SATs definitely look better on 2 liters of nasal cannula. He's in no acute or apparent distress. He denies any shortness of breath. You auscultate decreased breath sounds and coarse crackles in the left lower lobe anteriorly. His skin is pale, warm, and dry. He has a productive cough. What we've moved to rust to yellow. And he complains of the left side of his chest has pain when he coughs. All right. So, is he recovering as expected? Yes or no? I'd say he's moving in the right direction, but I still have some concerns. Would you guys agree? Okay. So he's beginning to respond to therapy, but still has symptomatic community-acquired pneumonia as evidenced by his lung sounds, elevated temperature, elevated respiration, and need for oxygen therapy to keep SATs at 94%. Although the sputum is no longer rust-colored, he has yellow, which is expected for several weeks after an episode of community-acquired pneumonia. So based on your evaluation, write an outcome to achieve by the end of your shift, and then list 6 priority interventions you will perform towards achieving this goal. So in your clinical settings, no matter where you are, you should have an outcome for the patient. You should have a goal that you're focusing on. And the goal can't be something you won't ever be able to evaluate, because your shift ends at 7 o'clock or 6 or 6:30 for some, depending on, what time you start. So just, have a focus for the day for your patient. Otherwise, you're just running around doing a whole bunch of buffoonery without any type of structure. So in the essence of time, one that could be worked on is, absence of crackles, SATs 98% on 2 liters of oxygen, or, has the SATs at 94% on room air, normal airflow, maybe be afebrile, monitor vital signs every 2 to 4 hours and pulse ox, check breath sounds every 2 to 4 in mental status, administer oxygen as prescribed, titrating to maintain SATs over 90. Perform cough and deep breathing exercises every 2 hours. Get them up as tolerated. Maximize fluid intake by maintaining ordered IV therapy and promoting oral fluids as tolerated. So all of those are potentials that can go down during your shift. Antibiotics as prescribed, and then respiratory treatments as prescribed. So we're at the end of the shift. Which of the following assessment findings would best indicate that he's responding to therapy? So all those things that you said up here, so maybe he could be afebrile. Maybe he's up moving around. Maybe he's coughing. And actually, here's some choices. So let's see. Which one would you go with?
The end of your shirt.
A, B, C, or D?
Cough productive of yellow skin 96 on A.
So several folks say A. I would agree. So if he's responding, we would expect improvement in symptoms. We would not expect continued complaints of dyspnea, crackles in the lower posterior lobes, or fever. A SpO2 of 96 on room air is satisfactory. Although clearing of sputum is preferred, a cough productive or a productive cough of yellow sputum could be expected for several weeks. So here's our case progression. So he's there continuing the plan of care for 2 more days. He recovers from the pneumonia. He's getting ready to go home. Now what? So you know that CK has got an increased risk of contracting another infection. So 4 strategies that we can add to the teaching plan. So immunizations and the flu shot and the pneumococcal vaccine with the booster, and that's actually now 6 years. I thought it was 5. Stress the importance of obtaining a yearly influenza. Stay away from crowds. Stay away from sick people. Hand washing. I love it. Avoiding exposure with people with colds or flus during the flu season. And teach good hand washing techniques. I'm telling you, hand washing is the key. He wasn't a smoker. I don't think he was a smoker. But teach how to handle and dispose of secretions. How about not being around smokers? I would go with that one. No lung irritants. Exactly. Teach the importance of oral fluids to thin pulmonary secretion and facilitate expectoration. So he says, my wife died a year ago and I live alone. I've been thinking, this pneumonia stuff has been a little scary. How will you respond? So you tell him you thank him for sharing and see if he wants to talk about it some more. I would be concerned about social support because if he's by himself, he's going to need a little bit of help. So he may need home health for a couple of days. Does he have any family or friends that can look after him? Does he have any issues with grief or fear of death, loneliness? Does he get his meals? His shopping and laundry? Make certain his concerns are addressed in at least one concrete arrangement before he leaves the hospital. What are some community resources that he could benefit from? Senior center. Oh, that's a great place for the elderly population. And they do a lot of, organizing classes and crafts and all of that, outings, and they take them shopping and grocery shopping and clothes shopping. Sometimes they do like little dinner nights together. They do little social events like bingo and gift giveaways or silent auctions. So that would be a good thing to do or to suggest. Churches, health clubs, service organization, educational classes, travel clubs, local community colleges, just like El Centro, they offer a whole track under the continuing education side for elderly. So things that they can do, ballroom dancing and all of that. Special interest groups are good places for them, for people of all ages. So if they like to travel, then hey, join a travel club. And I think that's the end of that particular scenario. So from an educational standpoint, we want to make sure that, we're doing and teaching them to use the incentive spirometry at least 10 times. So, every 1 to 2 hours while awake. Keep hydrated, so 2 to 3 liters a day to help thin the secretions. Unless they have heart failure or renal failure, then we are not going to have them drinking 2 to 3 liters. Fevers do dehydrate you, so you end up losing about 300 to 400 mils per day with breathing. Making sure they turn frequently, to keep secretions moving, keep the head of bed up at 30 degrees, especially when eating, to minimize the risk of aspirating and ending up with an aspiration pneumonia. We already, as we told him in the case study suggested, vaccines, making sure they're up to date, getting the annual flu shot, also getting the pneumovax. Stop smoking or not being around people that smoke. Avoid sick people, crowds of sick people during flu season. Washing hands, taking medications as prescribed, like the antipyretics, like your Tylenol, your Advil, or your ibuprofen. Increase fluids. Take your bacterial antibiotics for the bacterial pneumonia. And if they have, a virus, then, they'll take an antiviral antibiotic. So the antibiotics is going to vary, but there's some mainstay ones that, that may be used. Sometimes they start off with a penicillin. It's a narrow spectrum, which means it doesn't cover a lot of bacterias. But the problem with penicillins, like penicillin G, they have to be concerned about hypersensitivity and anaphylactic reaction. So if you do take penicillin or some antibiotics, they'll decrease the efficacy of birth control. So we need to tell patients to use extra precautions. If an individual is allergic to penicillin, then they'll give them a cephalosporin. And cephalosporin would be like the Rocephin, which is what he got, the Keflex, or anything that has cepha in it. There's several generations, but they may start them out around the third or fourth generation because it's a broad spectrum, gram-positive, gram-negative. Fluoroquinolones, that's the Levaquin or levofloxacin. This is a broad spectrum antibiotic that also treats respiratory infections, severe respiratory infections, especially if it's a resistant form. The side effects of Levaquin is C. diff, which is a GI infection, so C. difficile, tendon rupture, and prolonged QT interval. But overall, it's very it works really well. Tetracyclines or the doxycycline. This is a broad spectrum antibiotic, but we don't give tetracycline to pregnant women or to kiddos less than 8 years of age, and that's because it causes discoloration of the fetus's teeth. So even though the teeth haven't grown, when they do grow in, they're going to be stained kind of a brownish color, and it can also retard or stunt their growth. So that's another reason why they don't give it to pregnant women with that are with kiddos in utero, and the other reason why we don't give it to children where the bones have not calcified. This one will also decrease the efficacy of birth control. No milk products or antacids because it will affect the absorption of the medication. So although it is a broad spectrum and it treats gram-positive and gram-negative rods, there's some other side effects that, something you may not want to be, or a patient may not want to be associated with. Macrolides, which is our Azithromax or the Z-Pack, where they take the 2 tablets the first day and then 1 tablet for the next 3 days. So this is another narrow spectrum, so it only treats gram-positive bacteria. And they'll give that to patients that have also allergies to penicillin. If you have the funky bunch of the bacterias, then you're going to get vancomycin. And so that's usually given in severe cases when they're trying to treat extreme resistant bacteria, but we have to worry about autotoxicity when we're giving patients vancomycin. So those are all of the different types of antibiotics and educational purposes that, we can give or should, inform our patients. So we've covered UTIs, we've covered pneumonia, aspiration pneumonia, and sprain. So I think that covers all of the exemplars under immunity. I don't think we missed any. Any questions? All right, so other than that, we'll see you on Tuesday, and then we'll finish up with acid base. Start looking at some of that material because some of the exemplars that we've already spoken about, you know, it's just even when you hear the name, the first thing you should be thinking is, you know, it's respiratory acidosis or it's metabolic acidosis. So start looking at that material because we're going to go ahead and hit that, and then we'll close out for, you know, our third concept for the exam too. All right, guys, enjoy your Sunday, and we'll see you Tuesday.